Oh, hey, Chris.
Hey Chuck, how are you?
Fantastic. It's going to be a great day. It's beautiful in St. Louis. I think it's going to be reasonable temps. All good.
Absolutely. So today is the day where my daughter has decided she wants to take bike riding lessons.
Oh,
She is
God.
strong-willed, I think is the way to say it. And so for her birthday last year, I went out of my way to go down to the bike store and get her a like real quote big girl bike because she was turning 5. And it was time for her to learn how to ride. And she just looked at it and then refused to get on it. So, but for some reason, like last weekend, she's like, next weekend, we're doing bike lessons. I was like, okay. And, fortunately, my wife has been the one to teach our children to ride a bike. So I think it's because I'm the one who actually takes them out once they learn how to ride. So, yeah, it's a big day in St. Louis. We were just talking about the weather when I went upstairs. So,
That's so awesome. It's funny. My wife was the one to teach my children how to drive. That's more recent for us than the bike riding. Our first two learned to bike ride in a traditional fashion, and honestly, neither of them loved it. So we really didn't do a lot of bike rides in family. My third kid um, did like riding, and during the pandemic, we rode all over, which was super fun. But she learned to ride on what is it called, a glider, where it just simulates bike riding, and you kind of use your feet. It actually was cool. She learned to balance way sooner than the other two, but then you get used to using your feet to brake, and it causes all kind of problems on the regular bike.
well, I will say that my son did use the balance bike, and he's a great bike rider, and we did ride a lot during the pandemic. I remember a lot during the pandemic, early stages. But my daughter is not was not as keen on the balance bike. And to bring it to something closer to you, my wife has already told me I'm not allowed to teach them how to drive, which is great. I'm very happy about that.
Absolutely. It's not fun at all. Uh,
I don't think I drive aggressively. I just drive defensively. And to drive defensively, you have sometimes have to drive aggressively.
well said. I like that. I like that a lot. Yeah, I don't, I remember learning to drive, but back in the day, of course, especially in my family, we were learning to drive on a manual transmission. And so it was an old CJ7 Jeep with what they say, three on the floor, the big long thing, and it was three gears, and that Jeep would buck, and it was crazy. But it was my mom who taught me.
That is the most Alabama thing I've ever heard you say. My first car was a manual transmission, and God, I miss it. I actually still put my hand when there's now most cars now don't have an actual like gear knob, even for an automatic. But if there's a car like a rental car and there's a gear knob, I like put my hand on it still. I'm just used to putting my hand there.
Absolutely. But I say, and we've talked too much about it, but one more anecdote is that thank God I don't have a clutch, as I would be stuck at home with my knee recovery. I think I had my left knee done. I can drive to work. It would be a problem.
Oh man, you're right about that. You're right about that. But whenever, so we were on a vacation last year, and we were in Italy, and I loved getting the stick shift. I mean, it was great. It was such a throwback, so to say. But yes, we have talked way too much about that topic. But we have some really interesting cases to discuss, a kind of grab bag of emails and whatnot. But the upper hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join practicelink.com for free today. And you can actually specifically look for the URL www.practicelink.com / the upper hand. As we have discussed, I have many roles in the department. And one is that I head up our neurorehabilitation program, and I was really happy to hear that a candidate for our program found us on practicelink.com. So I have nothing to do with where our jobs are posted, but we post on PracticeLink.
Awesome, awesome. Well, PracticeLink is also going to exhibit at our WashU Nerve course, which is about 10 days away. So we're really excited about that. It's going to be a super fun course. So if you haven't signed up yet, if there's still spots, go check
May
us
not
out.
be. Yeah.
There may not be. And I did confirm if you just Google WashU Nerve course, you will find our course website.
Thank goodness, because I've been trying to find it to register. I just can't seem
I'm
to
sure.
find it.
I'm sure I'll save you a spot, Chuck. Don't worry. So we've got some interesting emails. I think the first one we got was from Matt Tamino, who is a practicing hand surgeon in Rochester and has written some good papers. And so you may know his name. But he emailed us about our Keenbox episode from a little bit a ways ago, and we said that that steroid injections were not advised in general unless the patient needs to delay surgery and does not change the course of the disease. And Matt was kind enough to let us know his perspective, and he says that his experience has been different. In patients with stage 2 or 3 Kienbock's, he thought that the acute development of pain may be more synovitis related as opposed to coming from the bone itself. And that a cortisone shot can really help with pain relief. He routinely offers it, thinks there's probably little downside, more like offering an injection for somebody with a small cuff tear that's painful without weakness can make a symptomatic patient asymptomatic. So that's his first point. He did bring us a second point, but Chuck, what do you think about that?
So, first of all, if Matt's listening, thank you. And I've known Matt for a long time, and he has a lot of interesting things to say. And at some point, he could potentially be a really good guest on the program. He's 100% correct. And it's interesting. You and I, when we first started podcasting, we worried that maybe we still do, maybe you still do. We worry that what we say gets memorialized, and we're like, God, if I say something stupid, it's gonna be out there forever. And I'm sure we've said our share of stupid stuff, and I don't think this is a stupid thing, but we just start a conversation, and sometimes I don't know if it's misinterpreted or it doesn't come out the way we want. I 100% agree with Matt in one sense, but I probably still disagree in anher. So I use steroid
You can't
injections.
100% agree and then in some sense disagree. So you're like 95% agree. Is that what you're saying?
So I do use steroid injections, and my speech to the patients is very similar. So I explain that if I'm giving a wrist injection, whether it's for Kienbocks or for potential TFC pathology, I'm giving the injection not to fix the problem, not to cure the problem, but to take away the associated synovitis and hope that the pain goes away short term and long term. But I don't know if it will. So it's not really a test because we likely know there's pathology, but it's a treatment for the synovitis, not the problem. What I don't like to do is repetitive injections, especially in younger patients, because I think we know that they can be detrimental to the good cartilage and the wrist joint's obviously complicated. So I appreciate Matt writing in. I agree with him, but ultimately it likely requires more than just an injection in the setting of Kienbocks. That's my take. What's yours?
No, same thing. I mean, I think steroids are a useful thing, and I will do radiocarpal injections for patients with Kienbock's in an attempt to try to quiet things down, because I agree that it is likely synovitis related. I very carefully talk to patients for pretty much everything, with the exception maybe of trigger finger, that steroids are not curative. Steroid injection is not going to stop this process from going on. It's going to make you feel better. It might buy you some time. But with the exception of trigger finger and the veins, I think, this is not going to fix it. And I'm very careful with my language. I think we talked about this before, that we can't fix people in many ways.
Yeah, I totally agree. And like for tennis elbow, I don't promise a quote unquote cure or a fix. For carpal tunnel, I certainly don't promise. In fact, I say that I don't know we've talked about this, but I don't remember your response. I tell people for carpal tunnel, a classic well, we give injections. I give injections for carpal tunnel in two settings. One, if someone just doesn't want surgery, yet they're a surgical candidate because they have classic carpal tunnel, or they want to delay surgery. And then I sometimes give it as a diagnostic test. But if I'm giving it as a treatment, I tell patients that I expect less than 20% will still be improved 1 year later, to the point that it's almost never a cure.
Yeah, no, I think when we had we reviewed an article, a large series from Scandinavia, probably about 2 years ago in Journal Club. And the take home was that 85% of people who had a steroid injection for carpal tunnel still had surgery within a year. And that's the number that I quote. Our residents and fellows have heard me quote that. And I think that's really, good. So if you tell somebody like, look, this will kick the can down the road. Clearly our experience and our interpretation of the literature is biased because we read surgical literature and we are surgeons. So there is a vast number of papers out there that would support the use of corticosteroid injections to treat carpal tunnel, perhaps definitively. It's just not my experience that it works definitively.
Right, right. Yeah, so it goes back to the basics of just conversation with the patient, and it's been fun. As I've mentioned, my son's a first year med student, so he's on a clinical rotation now for the first time. So in the first year, they get into clinic, and really not the clinic, onto the floor, and it's just amazing. Like, and it's actually rejuvenating is the wrong word because I don't need rejuvenating, but it's inspiring sort of to kind of see the world through a first year medical student's eyes. It's amazing. Like what we do, what we have the opportunity to do is amazing. And watching him soak all this in and learn and have perspective is awesome. And so some of these things about fixing and about perspective and about really talking to the patient actually means more to me today than it did before he started med school.
Yeah, absolutely. I mean, I think if once you get the appropriate perspective of what we get to do as surgeons, you're like you're meeting somebody, sometimes literally right before you take them to the operating room. You are cutting into them. I mean, for lack of a better term, it's a very intimate relationship, especially for somebody doing hand surgery. So you're like literally holding their hand in the preoperative examination. It's incredible what we get to do. And I think that getting to see that perspective as your son goes through it is, appropriately like, gives you the right perspective in terms of what we get to do.
Yeah, and I think it is for him, it's been fun because it sort of has started to demystify what I do and also just make it more real, like with complications and with challenges. It's just a really interesting.
Yeah, no, he gets to respect dad a bit more, seeing what dad does. So
Or less. I keep telling him to look at other specialties, but he keeps coming back to orthopedic surgery. And we have so many examples in our department and our world of this. But we know orthopedics and plastics and the therapy life, which one of my kids might pursue, is we're all lucky.
well, I mean, it's pretty cool what we get to do, to be honest with you. I mean, you don't have to, you're not dealing typically in orthopedics with in plastic surgery with life and death, although there are I remember the neck fash case I did as a fellow, and actually, I think that's probably the only time I saved a life was with the neck fash case. But other than that, it's you're dealing in different margins. So yeah, I mean, actually, your point about your son and surgery and that kind of thing is really interesting because we had a response, an email from Bob Vandermark, and Bob is a great friend of the podcast, and mentioned that we talked a little bit about doing Dupuytren's surgery a couple of episodes ago. How do you feel about Dupuytren surgery awake? Because that's Bob was trying to tell us that doing wide awake for this has some advantages, and I think clearly it does. And he sent us a nice article from Don Lalonde's group about kind of pearls about doing wide awake surgery for dupes.
Yeah, in the right setting, in the right patient with the right kind of dupes, I totally agree. And I see the benefits. You have less bleeding. It's a procedure that can go quite smoothly and be quite predictable. My concern is that sometimes these are, and maybe Bob's not suggesting we do these for all cases, but it can be a longer case, it can be a more challenging case. It's just in our setting, it's not been easy to do. But I will say I read the article. Thanks, Bob, and thanks for writing in. And I think it's a fair suggestion. And for the right patient in the right practice setting, I think it makes all the sense in the world. What about you?
Yeah, no, I've actually done some wide awake dupes, and it's not my default, but I mean, I think if I'm doing a dupes in somebody who is clearly at risk for having anesthesia related issues, at least from my rudimentary understanding of that, I do it. So it's not something. To be brutally honest, it's just harder for me. Like, it's just like I can do it. I can do it well. It's just more stress because dupes can be stressful, as we talked about. Like, like I think I said on the last episode that, it can be a very humbling disease process and a formidable foe in surgery. Because just when you think you understand Dupuytren's disease, it throws you for a loop. So, and I don't want to be thrown for a loop while the patient's awake, especially if you're heavily involving a learner.
Well, that was my point. And I think that's exactly right. There needs to be verbal interaction, comfortable verbal interaction with a resident or fellow in what you're seeing and what you're doing. And that can be tricky in these situations. And so that's the balance. I think if I was not in a situation where I was teaching, it might even make more sense if I was working with a PA, for example.
Yeah, no, absolutely. And I think that, so this article that Bob forwarded us is in PRS Global Open, so people can go download it for free. It's called Tips, Tricks, and Pearls for a Superior Patient and Surgeon Experience for Wide Awake Dupuytren Surgery. First author is Natasha Barone, and the second author is Don Lalonde. I again, Like if this was like I'm doing 3 cases in a day and I have all the time in the world, and I could just sit and let the block set up for half an hour and all this. It's actually really challenging when you're, to be honest, running 2 rooms and you're kind of bopping back and forth, et cetera. Like for me, like when I'm doing my normal 2 room flow and our learners will attest to this, I'm actually going out and blocking patients between cases because I'm doing that in holding, so it can set up for a reasonable amount of time. So to then incorporate a block that is admittedly going to be a little more involved and take more time to do than a carpal tunnel or trigger block is a bit of a logistical challenge. And I know the practice settings are different in different environments, both in Canada and in the US. And ultimately, we do what's right for the patient. But if there's a margin where it's not going to make a terrible amount of difference to the patient, and I have the choice between doing it under anesthesia, general anesthesia versus local, I may just pick general for a lot of things.
Yeah, so yeah, I think that's again good points, and I completely agree, especially with the block the way our system works and when I block the patients. So I hope that I am blocking them 20 minutes in advance of the surgery. Because what we all know is the lidocaine is going to take effect, but the epinephrine may not. And of course, in Dupuytren's, it's more important that you have a bloodless field. And if you do, fantastic. But there have been some carpal tunnels where I didn't have enough time to let it set up appropriately. And of course, everything was fine and it was safe and et cetera, et cetera. But for Dupuytren's, you got to get it right. And maybe that patient comes in a little earlier, you block them a little earlier, you can get around it. But just another hiccup to kind of the busy day for some of us.
Yeah, no, there's some really good pearls in here. Perhaps my favorite one is using the late night FM DJ voice and manner to reassure them with your soothing voice during the surgery. But they do talk a little bit about some of the logistical things about how having somebody checking their blood pressure and hearing, the beeps of the anesthesia machine when they're checking vitals. I cannot agree more. It is super annoying, and what patients complain about the most is the darn blood pressure cuff, and I cannot get it out of our system because I think the AORN has a recommendation that vitals be monitored routinely for patients who are having procedures in the operating room, whether it's under local or not. And I just can't get a way around the policy.
So we had a good conversation yesterday. We had some folks come in to consult about our what we call the OC, one of our outpatient centers, looking at efficiencies. And one of their recommendations, which Ryan Calfee and I certainly agree with, is should we, and as you have done at your facility, use our procedure rooms for hand surgeons and have a day or have a bounce room where you can do local only procedures and crank. And there are certainly stories out there of getting 20 cases done of carpal tunnels and triggers and simple things. And I know those are true, and it's a beautiful thing. Our system, as we've talked about, is a little different. But one of the things I said is that, yes, that could work if I gave one of my rooms to a partner, kept one of my rooms, and had a procedure room as a local only room. That could absolutely work. The problem is our pre-post area would be filled with people. Even if they don't stay long, our current process is, they have their procedure, they go recover for 10 or 15 minutes, even they don't need to recover, and then they get dressed and they go home. And I said, if we're going to do that, then we have to change our process, which I don't know if we can, right? They need to wear their street clothes and they need to, as this article says, get up and walk out the door, not be on the stretcher, taken back for even a brief recovery in the recovery room. So the article does have some nice pearls.
Yeah, no, I think if you were to redesign the system, so if there's somebody out there that's about to start their practice and says, this is how I want to do Lalon surgery, clearly follow the pearls in here about room setup and everything that Lalon follows. I mean, I can't remember whether I saw him talk about this or read it. Like he'll have somebody else, he'll have everybody come and he'll have 5 or 6 people that get blocked by somebody else and they just sit there in the waiting room until it's their turn. And that's just not the flow in our particular practice setting. And I would imagine most large academic centers.
Yeah, exactly, exactly. So the other thing we had with these consultants was I really like, and I think it's just such a truism that we all say that politics, all politics is local. All healthcare is local, and it is all, and it's hyper local. Our center is different from a center across the street based on the hospital system and so many different factors that yeah, all of these recommendations from experts or wannabe experts is very dependent on your setting.
Yeah, absolutely. I mean, I think that even going between, South or two of our different centers, I go to South County, you're in Chesterfield. I mean, there are differences when I go to different places.
Yes, absolutely. Um, why don't we thank our other sponsor?
Yeah,
Um,
absolutely. Our sponsor, Checkpoint Surgical, is a corporate sponsor of the upcoming Mayo Clinic International Symposium on Surgery of the Spastic Upper Limb on June 4th to 6th in Rochester, Minnesota. The course is a comprehensive multidisciplinary program directed by Dr. Peter Ree and Dr. Michael Weinberg on the procedural and surgical management of the spastic upper extremity. Peter, great guy. I'm sure it's going to be an awesome course.
To learn more about the course and other upcoming educational programs supported by Checkpoint Surgical, including our very own program here at WashU coming up soon, please visit nervemaster.com.
That's right. As we mentioned, the course is about 10 days away at our WashU course, and spots are going to be, really maybe hard to come by. I mean, I think we'll have some standing room opportunities, but it's really cool. I mean, the cadaver lab is going to be really decked out technologically. We spent a lot of our funds trying to get the appropriate television screens and camera setup. It's going to be really cool. So, yeah, I'm sure that, and I know the Mayo Clinic does a really nice course too. I've been up to their brachial plexus course back in 2018, I think, the last time they had it, and it was great. So, yeah, check that out. Thank you to Checkpoint for supporting that course and for supporting us.
Absolutely, absolutely. We had a couple of, I'm not sure if we have any other, I don't think we have any other questions or mail to discuss. We had some cases we thought might make some sense.
Yeah, absolutely. Let's get on to some cases.
All right, which one you want to start with?
You talked a little bit about pinning. I think we haven't talked about pinning fingers in a while, and I think that in general, how do you approach pinning versus more stable internal fixation? I guess we could probably start just in general with metacarpals versus phalanges. I remember an old Marty Boyer quote is plate metacarpals and pin phalanges. Is that still true in 2024?
Yeah, I mean that was a truism, and that was absolutely our approach here at WashU. And that is not what I would say is the case in 2024 here at WashU, thanks to some technological advances. So um, it's interesting. I just saw an X-ray of a relatively transverse fourth metacarpal fracture, markedly displaced. It actually had an extension, a long extension, all the way to the joint that was completely non-displaced, and kind of debating what the best approach for that is. And when I'm taking care of kids, Lindley Wall is my partner. This child may come to the shrine as an early adolescent, and the question becomes, and Dr. Wall is, I would say, a master penner and does a huge number of these type of cases, and she pens everything, does it very well, and has really good results. And the price is right. For metacarpals, we have talked about on this podcast, I increasingly try to stay away from big open incisions, from plating at all, and have used a lot of retrograde screw fixation, non-compressive or compressive, depending on the fracture pattern. And so I think that's absolutely my go-to for most of these, but some require, a lot of thought and preparation.
So yeah, I think those are really interesting points, and I think a lot of us are going to headless compression screws or non-compression, just headless screws or intramedullary fixation, I think is the right term, for metacarpal fractures. I think there's certain patterns that are more amenable to that, and some that are, that are would not permit it at all. And I've learned the hard way. So what are the patterns on metacarpals that you think, hey, this is going to be great for intramedullary fixation versus the ones you're like, I'm going to stay away from that?
Well, um, first of all, I don't think the availability of this surgical technology and these intramedullary fixation options should necessarily change our general treatment. So whether that be surgical or non-surgical, there is an argument to be made, like in many spots, about early fixation and getting patients out of immobilization, and that can make a lot of sense. But shaft fractures in general are, we can tolerate less deformity, classically apex dorsal. We can tolerate less of that. And shaft fractures are typically transverse or close to transverse. And those are perfect indications. And I think with a great reduction, a compression screw can still make a lot of sense. And I haven't seen a difference between compression screws and non-compression screws in shaft fractures as the first category.
Yeah, no, I agree with that. I mean, it's nice when you add a transverse fracture in a shaft. I think where I've had to do a little more troubleshooting is, when the obliquity of the fracture has led, um, uh, there was one case recently where the obliquity of it was a fourth and fifth metacarpal shaft fracture, but the fifth had a little bit of obliquity, which led the guide wire to go outside, to deviate away from the fracture. So like not if it was in the fracture or in the distal part, but then as we were introducing the wire, it just kind of propagated out of the fracture instead of getting into the proximal part of the metacarpal shaft. So that was a little bit tricky. And clearly, I mean, we spent some time troubleshooting that and it went really well. And we got all the benefits of the intramedullary fixation. But I think the obliquity can sometimes be tricky. And I've also seen that happen in, proximal phalanx fractures when I've tried to use headless compression screws in essentially as collateral recess pins without having them stick out of the skin. So I think there can be some, there are definitely some pearls there. I think the big concern that people have about using this intramedullary fixation in a metacarpal is what if God forbid, what if it gets infected? What happens there? Like, what are you dealing with then? And I think that that's a very reasonable concern.
It's a reasonable concern, and that goes to the point of don't overbury ideally, so that you can find the screw and take it out. Knock on wood, I've never had to do that. I have seen some bent screws, but ultimately I've never had to really dig to remove a screw, and I don't overly worry about the cartilaginous entry point. What happens to the cartilage there? I just think there's plenty of evidence. First of all, it's pretty dorsal. I don't worry about it. Going back to your original question and building on what you already stated, it is the distal fractures that provide the most challenge, I think. Yes, these can be transverse, but in my experience, at least the ones I've struggled with both recently and in the past have been those oblique fractures, which are super interesting because number one, they often go really distally. So they're not ideal for plating either because they go basically into the joint with you when you think about the capsular reflection. And I have a really low threshold for just using a pointed reduction clamp, whether closed or open, to secure the fracture. And then once you secure the fracture, you put your non-compressive intramedullary screw in, and I think you're done. And it actually it simplifies a really difficult fracture pattern. And I've been really happy with some of those.
Yeah, no, I think that's well stated, and I think that it is the distal kind of neck head fracture that that can be really challenging to try to address with a plate that I used to go to bouquet pinning for. So I'm not doing that as much because I think that the technique you described with an intramedullary fixation can be very useful.
I think we should, for many of those who have never heard of bouquet pinning, and we should probably describe it because I learned that in fellowship, and I would say technically it's not always easy.
No, it's not easy. It's actually a really good technical exercise, to be honest with you, for our learners and for us. I mean, so you're pre-bending some K wires and inserting them into the base of the metacarpal, kind of just after the joint surface, and you're introducing them in a manner in which you're shooting them. You make a small little opening in the metacarpal with an awl, and you're introducing these pre-bent pins, kind of like flexi nails, I guess is the most appropriate analogy, like for a Pete's case. And you're putting these pre-bent pins in and shimmying them up the shaft across the isthmus, and then splaying them out and turning them in a way that it props up and reduces or supports your distal fracture. So a neck or a fracture that's kind of at the head neck junction, it can work beautifully. It's awesome fixation, and oftentimes, you do have to remove them, but sometimes you don't. And it gets you really solid fixation, especially if you have, two or three, pins and K wires in there that are supporting and splaying out and providing multiplanar intramedullary fixation. Is that appropriately stated?
Yeah, it's really good. So before we had the well accepted option of the intramedullary screws, I did a lot of pinning of metacarpals in an effort, especially in the adolescent population, in an effort to avoid plates and screws for all the negatives they have. And just to be very clear about the negatives, not only is it a bigger surgery, but you have a real risk of creating scar tissue and limiting function and having to go back and tenalize and or take out the plate. Um, but the antegrade K-wire especially for the fourth and fifth metacarpal, is something I struggled with a lot. And there's no, the fourth in some ways could be easier depending on the patient's individual morphology. And what I did on more than a few occasions was bury, as to your latter, to your point, bury a single big K-wire down the shaft of the fourth metacarpal. The facet that we aim for at the ulnar base of the fifth metacarpal, sort of right adjacent to the insertion of the ECU, is tricky. It's tricky to hit, it's tricky to expand, and so these retrograde options are far superior.
Right, absolutely. If we were to have like a technical trial thing for people, practicing hand surgeons, like a Olympic trial kind of thing, I would put bouquet pinning as one of the things. Like, you got to repair a nerve, you got to repair a vessel, you got to do a bouquet pin, you got to put a distal radius plate on. Like, as a technical challenge. I think it's a really good one to do, and one in which you can separate the grown-ups from the kiddos, so to say.
The hand surgeon Olympics, I like that. I will say a few weeks back, I had a day shortly after my surgery where I was coming back, and I asked for just a half day, and I had some great pediatric and congenital cases. And then Dr. Wall must not have been available, so I kept adding on fractures, and I ended up with 4 or 5 fractures. And one of them, and they were phalangeal fractures or metacarpal fractures. I pinned them all. And one of the metacarpals I pinned, and I think in a young adolescent, often with a boxer type fracture, a young adolescent male who punches something. I don't know that that situation necessarily benefits from a screw. And I think putting K-wires in for 4 weeks is well tolerated. And putting a cast on or however you want to handle it, I think it's very appropriate treatment.
Yeah, I think for metacarpals, I think people will move their fingers with pins for a metacarpal. I'm less likely to see people move their fingers with pins for a phalangeal fracture. Do you agree that in general that holds?
100%. And it's interesting. It's very patient dependent, obviously, but totally agree. Right. So you can get away with early motion of the IP joints typically, and hopefully of the MP joint with a pinning of a metacarpal. It is tricky, especially with younger patients when you get into the phalangeal fractures. So, what has your experience been with we've seen some marketing about the headless screws, intramedullary screws for phalangeal fractures. Have you done it often? Have you done it at all?
I have. I won't say I do it often. I like it. If you can, we talk about with say like a relatively transverse proximal phalangeal fracture at sort of the base. That's extra articular. That you would typically use a collateral recess pin for. So introducing a pin essentially at the insertion of the collateral ligaments at the base, and then shooting your pins distally, in typically a antegrade crossed pattern, ideally crossing distal to the fracture. Um, I've used headless compression screws as a substitute for collateral recess pins that essentially act as internal fixation. So you get the benefits of percutaneous fixation, percutaneous approach with the benefit of internal fixation. In the right pattern, that's awesome because it really works well. And I think if people are on social media and stuff, there are some surgeons that are pretty good about posting their different constructs and seeing all the kinds of options. And that's where having a range of sizes on your headless screws can be useful. But sometimes it doesn't work out. And then you're left with, you've already kind of made a big hole and you're dealing with, sometimes the pattern is such where if it does have an intra-articular extension and you don't recognize it, it can be super challenging.
Absolutely. So I just looked up the ones we use, and I do have a conflict of interest, but not about this particular product. These are the ones we're referring to are the Exomed nails, and for the metacarpal, they are called the N8 for those who are not familiar, and for the phalangeal fractures, they're called the in-frame. And I say that I work with Actimed on other things, but not on this. And this product was developed by an external company, and it was acquired um, by oh my God, this product was acquired by Acumed. So let's
Well,
build
honestly,
on.
before you go into that, I mean, I you can use clearly you can use other headless compression screws, a lot of these companies, because I don't use the Inamed products, I don't use those. There are other companies that make headless compression screws, clearly. There are fewer versions that are not compressive, just straight
Right.
intramedullary fixation without your threads that are going to compress.
Yeah, well said and really important. Absolutely, because you're right. We don't have these on the shelf, and so if I want to use them for a metacarpal or wherever, and to me, again, the most important time to use the non-compressive is an oblique fracture where you don't want to compress. Good point. Yeah, I think I have done these a few times. I have to say, I just may not be seeing enough and doing enough to be facile. I typically use K-wires. Occasionally, I'll still open and do multiple, small fragment or modular hand type screws. But I think, if you have to observe the basic principles, right? You want a stable reduction that allows early motion. And that can look a lot of different ways and be effective. And you have to consider cost, time in the OR, all those things matter. In the pediatric population, where I do see perhaps more than you, K-wires are usually the answer. And the difference being, and this is super important, all the therapists will recognize this, it's super important for the simple reason that kids are less likely, not it does happen, but they're just less likely to get stiff. They're also less likely to participate in early motion. So it's just interesting facts.
Yeah, no, I think that proximal phalanx fractures and PIP fracture dislocations are some of the most humbling fractures that we have. And I've seen former presidents of the Hand Society at multiple institutions be humbled by phalangeal fractures. So I've been really challenged by some of these. I remember recently there was and Adam Mosa will remember this. There was a day where I did a full clinic, and then there was a proximal phalanx fracture that I tried to be cute and add on at the end of clinic in the OR, and it was much more challenging than we thought. And it ended up looking great, and we were happy with how it went, but it was not certainly not plan A, B, or C in terms of the final fixation strategy. But like you said, like you've told me on multiple occasions, you got to be happy with how things look when you leave the OR, and we were happy with how things looked. We just wish we had gotten there much sooner. As we bring this to a close, I wanted to ask you, how do you handle your pins? So how do you think about, cutting your pins externally, whether you bend them before you cut them, what kind of caps you put on the pins, what you tell patients about the pins? Because these little things I think can matter sometimes for our trainees or learners, excuse me.
Yeah, so super important question. I want to get to that. And I want to say something that is important along that conversation. Thankfully, if you do use pins on phalanx fractures and you put the pins in a way where it's safe, you can choose to leave the pin proud at the insertion site, or you can choose to drive the pin in, whether it's antegrade or retrograde, and have the pin exit at the other side of the phalanx. And that's a nice trick to keep to stay aware of because it can help you manage the patient postoperatively. And so Dr. Wall has taught me, and again, this is Lindley Wall, who is one of our hand surgery partners who is really focused on pediatrics. So in the pediatric population, there's an entity called a subcondylar fracture, which is essentially just below the typically proximal phalanx condyles, and they typically just tip backwards. And so they're unstable, so you reduce them and you put pins, and you can choose to leave your pins out distally, and then they can be a little bit problematic. They also bind the collateral ligament, or you can drive your pins in a retrograde direction and have them come out proximally, in which case they're less problematic and potentially bind the joint less. And so I'm not suggesting that works for every fracture because there are benefits to having your pin long on the smaller fragment side, if that makes sense. But just be aware that external placement of the pins, you can have choices no matter what your fracture looks like. So that's the first thing I would like to say.
Yeah, I think that's well stated. I think that we had to use that technique in this fracture I was talking about after clinic recently. So yeah, totally agree.
Yeah. So the second thing is I do not bend pins typically. I will sometimes, especially if I think it helps me move the pin away from the skin. So if it feels like the pin's gonna put too much pressure on the skin, I will use two needle drivers and carefully bend the pen away from the skin, but I don't routinely do it. And my whole one of my most important concepts to think about with pinning is not to violate the far cortex, go too far, and then have to pull your pin back. Because then I think you have an unstable or potentially unstable pin, and then you have bigger problems. So I hopefully emphasize to learners that we're carefully engaging the far cortex and taking a lot of care not to go too far.
Yeah, I tell them to park it in the far cortex.
Yeah. Yeah, perfect.
Um, One thing that I learned in fellowship from Ryan Calfee was that, you want to take your if you're going to bend the pin, you want to take your needle driver and hold it proximal, I guess, to where you're going to bend the pin to make sure that that stays nice and stable. Because, I think theoretically, and I've seen it happen, bending the pin can displace your pin itself and affect your fracture. And I usually hold it proximally there with to where I'm bending it with a heavy needle driver, and then I use a Fraser tip suction thing, and I put the pin inside of that and use that to bend because it gives you a nice lever arm for that. I have when I put pin caps on, and I've gone away from using kind of the less expensive pin caps and use going to Jergen balls, mainly because I've had some
Wow.
patients, and the Jergen balls are not terribly expensive, to be honest with you. Mainly because I've had patients kind of get freaked out by the fact when the pin caps just dislodge during like routine care, and it just kind of freaks them out. So like, all right, like the Jergens balls are less likely to come off during that process.
Yeah, all well said. I tend to use pen caps just because they're a little cheaper. And I think, yeah, to your point, you want your heavier needle driver as close to the skin, even pushing the skin in a little bit,
Hmm.
and
Hmm.
either bend with a Fraser tip or bend with another needle driver. Totally agree. And you're right, you can displace the fracture with non-careful bending of the pen. Super, super important. Um, how long do you have any hard and fast rules about how long you leave the pins in? I have some thoughts, but I'm curious to yours.
However long I can get from the pins typically. So that tends to be somewhere between 4 to 6 weeks. A younger kid who with the predilection to heal quicker, probably 4 weeks. But in an adult, it usually ends up being 6 weeks. If I can get 6 weeks out of it, I counsel them pretty routinely that a pin site infection is a pretty common thing, and we usually treat that with some oral antibiotics. And if I can get 6 weeks out of a pin, I will try to get 6 weeks out of a pin.
Yeah, I think that's well said. So for adults with proximal metacarpals, those are always 6 weeks, and they're big K wires, 6.2s often, 4.5s at least, or 5.4s. These are the American system
Yeah, I was gonna say like
measurements.
we actually have a chart in my OR in South County with like conversion of like 4.5, 5.4, 6.2 into millimeters because the reps all come in talking like especially if we're gonna do like headless compression screws. I ask them what size the wires are that the guide wires, and they tell me in millimeters. I'm like, what's that in American? So we have a
So
chart for this particular situation.
it's so true. For distal metacarpals, I typically use the 0.045s, and those stay in typically 5 weeks. And then phalangeal fractures depends a little bit on exactly where they are. But in adults, it's typically 4 to 5 weeks. And in kids, it's typically 3 to 4 weeks. Because I think you can safely take pins out in kids much earlier, which then untethers things and lets them start moving. Because many kids will just not move if they're pins in. And I don't even try on a lot of them. I just put them in a cast in the OR, see them back at 3 to 4 weeks, take the cast off, take the pens out, and then go.
What do you use as your markers to say when a fracture is healed and ready to remove, or at least healed enough to remove pins? Are you going fluoroscopically or are you going by tenderness? Like, what's your guidance?
Yeah, I wish there was a hard and fast rule for me. There is not. I think time is probably the most important thing. In a reliable patient, pain at the fracture site can be helpful with palpation. I do think callus visible, which is often the case for metacarpals, is less commonly the case in adults with phalanx fractures. Kids will show callus, but in my experience, adults don't. And so you kind of have to just go with your gut and go with the time.
Right. And if you're getting fluoroscan images, it's easy to show the patient in real time. It's helpful for me that if they're non-tender or minimally tender to say, all right, we're on our way to healing. But you have to counsel them that the fracture line in terms of disappearing, like you would see in a long bone, that takes a long time to happen in the upper extremity. And I think that the clinical or biologic healing is in advance of the radiographic signs of healing. And I think getting in front of that messaging is important, particularly if you're sending them to radiology for formal x-rays, in which they will see the radiology report saying that the fracture is healing as opposed to healed. But if they're, quote, healing and they're non-tender, to me, that's healed.
Absolutely agree. Absolutely. Yeah, I think to bring this to a close, I do think pinning of fingers is a skill set. It's like many things in surgery, some people have that three-dimensional sense and can do it immediately. Other people have to develop that. It is an acquired skill set for most of us, but it's a really important one for the hand surgeon.
I will bring this to a close by repeating a story that I had in my fellowship year that often tell our residents and fellows that when I scrubbed with you early on in the year when I was a fellow, and there have been numerous trainees or learners that have come from my residency to this fellowship, and we were pinning a finger fracture, and you looked at me with such frustration and exasperation and said, "You residents from this program never know how to pin fingers." And I looked at you like, because nobody ever let me do that. So
Well,
thank you for that educational opportunity, Chuck, when I was your fellow.
doesn't sound like me at all. I have
There might
grown
have been an
so
F-bomb in
much.
there too. So
I've grown so much since that time. My patience has expanded so much.
yes, now because your son's a medical student, so you're starting to feel like what your son would be like as a resident. So I get you. Anyway, that was fun. I didn't think we would talk that long about pinning stuff, but I know there's clearly more we didn't even discuss. So,
All right, love it. Thanks. Have a great day.
all right, you too.
Bye.